Welcome to the Sharing Hall Antipsychotic Medication Reduction Conference Call. My name is Victoria, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode, and later we will conduct a question-and-answer session. I will now turn the call over to Kristi Wergin. Kristi, you may begin.
Thank you very much, Victoria, and hello, everyone. This is Kristi Wergin, and Kathie Nichols is with me, too, with the Lake Superior Quality Innovation Network, or the Lake Superior QUIN. We represent Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. I'd like to welcome you to the sharing call on reducing inappropriate medications. I see there's already a question about slides, and our slides available. This is an open call, and there's only like 2 slides just with the questions that we're going to pose today, so you don't really need to worry about having handouts for this particular webinar and sharing call. This collaborative event is the 4th and last in a series of learning events aimed at helping nursing homes use antibiotic medications responsibly. We started early in February, and we shared information about how to use QAPI principles when initiating a performance improvement project to reduce the use of these medications. And then we heard from a national expert on how to provide excellent care to younger populations with mental illness living in your homes, as well as a pharmacist who gave us suggestions on reduction strategies from a pharmacist's perspective. If you are unable to attend these live events, they'll soon be available on our YouTube channel. We also suggested that your teams complete some pre-work that was attached to each of the learning opportunities, and please contact us if you have any questions related to the work that your teams hopefully did together. This sharing call is designed to give nursing home teams an opportunity to collaborate with colleagues regarding successes and barriers related to the reduction of antipsychotic medications. Dr. Robert Sontek had planned on joining us this afternoon. However, due to a family emergency, he's not able to call in. However, we are pleased that we do have Dr. Jane Pederson available on this call to help overcome barriers that we hear about today. Dr. Pederson is the Chief Medical Quality Officer at Stratis Health, and she provides leadership and clinical guidance to Stratis Health's care quality and safety initiatives. She was on the leadership team for the Centers for Medicare and Medicaid Services Quality Assurance and Performance Improvement Demonstration Project, and she supported the development and implementation of the QAPI program through the development of tools and resources that are being used currently by nursing homes. She's a board-certified physician in internal medicine and geriatrics, and she maintains a clinical practice in the long-term care setting. So we're very happy that she was able to quit, at the last minute help us out this afternoon. Because this is a call, and there's about 50 on the call, and we're going to encourage you to everyone to participate in the call. To do that the easiest, we are keeping all lines muted during the call, but since we're encouraging to share, you can do that either in chat or you can get in queue to share or ask a question. So, Victoria, can you remind our participants how to get in queue for questions or comments?
Yes, if you would like to ask a question or make a comment, please press star then 1 on your touch-tone phone.
Star then 1. Okay. Thank you very much. Okay, so let's go ahead and look at the first discussion question that we have. We had hoped, so the part of the pre-work for this particular webinar is that we would hope that you would have given a little bit of thought of what were some successful strategies and what were some barriers that your teams might be having in the reduction of inappropriate medications. So hopefully you've come prepared. And we're wondering if any of you could please share some of the most successful strategies your teams have implemented to reduce the use of antipsychotic medications for persons with dementia. So either share in chat, or again, it would be star 1.
Star 1 done.
Yeah, star 1 to get in queue. actually, some of you have had some success in this. We've been working on it for several years now, and I know that a lot of you have been reducing the use of antipsychotic medications. Just wondering, what is it that really had the most effect in these efforts? Okay, we have somebody in the chat, thank you very much, who said they've started the Music and Memory program, and they've seen a great success with a resident who has explosive episodes at times, rummaging, etc. So the Music and Memory program, what's nice about that program, I know in Wisconsin, this program was, several years ago, many homes are participating in this through an initiative in Wisconsin. And then recently in Minnesota, we also got some funds. So I know a lot of nursing homes signed up, got a grant to do this Music and Memory program. And so it's nice to hear that there's been success with that. And I wonder, Stacy, if you could maybe add in chat anything specific about the little more details about the program and how you implement it.
Or chime in on the phone, too.
Or chime in on the phone. Yep.
Kristi, I was going to let you know that we do have Stacy in the queue on the phone as well.
Thank you. Hi, Stacy.
Hi.
Thanks.
So we started the Music and Memory program. We got the players out, I would say, it's been about a month.
Okay.
We've seen a lot of success with this resident where at night he would be up wandering, trying to rummage for food and different items, go into other residents' rooms on occasion. And now when he starts becoming restless or agitated and we put the music on, he will sing his song. And then the night nurse said he'll go from singing to tapping his foot, and then from there he goes to sleep.
Oh, nice.
Yeah, we've also seen with one of our Parkinson's residents that when she's having a lot of shaking and she uses it, she's able to feed herself a lot more independently while listening to the music. So we've seen a lot of success with it so far.
And then, so did you find out, like, in choosing music that the residents wanted to listen to, how did you go about that?
What they did is if the resident was able to tell them, our activity and our business officer went around and they talked to residents and their families. And so if the resident was able to tell them, they did that. If not, they talked to their children or their spouses.
Mm-hmm.
And so they were able to get the music from that. We have another resident that's restless at night, and the music that we had downloaded for her was polka music, and her husband used to go dancing a lot. And at night, it wasn't helping, and so we're going to try classical music for at night because we thought maybe with the polka music she wants to dance.
Oh, sure.
So, yeah, so it's just been kind of trial and error, but it's worked really well.
That's great. I've heard a lot of good things about that program, so it's nice to know. I'm glad to hear that it's working well at your home.
All right, thank you.
I know when the assisted livings I go to, sometimes they will just there's a couple of the TV channels that just have music.
Mm-hmm.
And so if somebody's like in resting or in their room, just putting that on, it doesn't have a visual, but it just has the music, and people really just enjoy that when they're in their space.
Good. Good.
Blues.
Yeah. When you're trying to sleep?
Yeah.
Yeah.
Well, kind of be more
calm
or sedate, sort of. Not so much the foot tappy blues.
Yeah. Anybody else want to share something that they've done that they've found really helpful? Some of the things, so Kathie and I, we've been making a lot of phone calls to nursing homes that are having trouble reducing the use of these medications. So we hear a lot about things that are working well and things that aren't working so well. So we'll just kind of maybe throw out a few things that might spark some of you to think of things you might want to share. And one is to make sure that you involve your pharmacists and your medical directors, your clinical providers in these efforts. They can be a really good resource for you. You should be probably a good idea to be having interdisciplinary team meetings regularly to discuss the use of these medications. It's not just up to like nursing. It's really an interdisciplinary process. So are there any of you that are can you talk about how you're using your interdisciplinary team in these efforts? We were lucky enough to hear from Dr. Derek Saunders, the consultant pharmacist. I think that was last week or the week before. And so I hope that if you weren't able to, like I had mentioned, if you weren't able to listen to this one, it should be available soon in the recording. So I'm just kind of looking at his slides and remembering some of the things. And he ended up with some kind of staff responsibilities and what information do you need when you are documenting a behavioral expression? So he did talk a lot about how a lot of people put in the notes, somebody's agitated, but that doesn't really say anything. You don't really get any good information. So it's a good idea to always include when you're looking at target behavioral expression that you're treating. What time of the day is this happening? Where is it happening? Where did the observed behavioral expression take place? Who was present during this event? Were there any environmental issues noticed? And has nursing staff completed a physical assessment of the resident? And are you looking at, he also talked about being a pharmacist too, the importance of really looking at what medications they're on and are these medications contributing to whatever the resident is displaying. So again, these are in the slides, and there's some really good ideas in there. I see that we have something in chat from Jennifer, who's saying there is an element of not admitting residents on antipsychotics if you can manage to coordinate this with the hospitalist, which I wonder when the quality initiative will start to get to the acute care providers in the clinics and hospitals. There's an element of not admitting residents.
Kristi, I think this is really an interesting one, and it's similar. I think one of the concepts that I've been, thinking about in my own practice, but thinking about also for the antipsychotics, comes a little out of the work that's being done on opioids.
Mm-hmm. Yes.
And because one of the things when I was talking to our state Medicaid director, and this is probably similar elsewhere, but when they say, look at our state data for people that were started on an opioid in the hospital, if that opioid is continued past 45 days, or if they start on opioid period, they become chronic users.
Yeah.
And I started to think, wouldn't it be nice to have some type of system where we identify that, whether it be an opioid or an antipsychotic, that maybe this was a new medication that was started in the hospital and have basically a time that this is expected to be off by. Our current electronic record systems aren't always programmed really to help us with that, especially if someone's going, between systems. But what I've been trying to do in the setting where I practice is assisted living. If somebody goes into the hospital or goes into an inpatient psych unit, which they occasionally end up at, I try to mark that timing in my notes, in my mind, and then have a goal for myself where now I get these medications weaned off. So my first visit, even after they come out of the behavioral unit, if they're now doing really well, is which med am I going to decrease first, and kind of make my plan right in my note for how I'm going to dial them back. Because I find so many times people go in, they just get left on it. And probably it was whatever the driver was is now gone.
A delirium.
Yeah. And if you have some type of plan and actually document that and track it, it really helps hold your feet to the fire. And I think this is kind of with the hospitalists. If we could get the hospitalists to sort of say, get in their note, yep, started on an antipsychotic because of such and such, should be weaned by da-da-da.
Yeah.
Consider weaning. And it's not, it could just be part of that, this is what's helpful to us because it gives us that trigger in long-term care to say, oh, this isn't a medicine that's just supposed to continue on, or this isn't something that's been on for 5 years. This was something new, like an antibiotic.
Right.
It's supposed to be done in 7 days, it's supposed to be done in 10 days.
Right.
The antipsychotic should be, weaned in 3 weeks or something. So, just a thought.
Yeah, it's a great thought. It's like how do you operationalize that? That's the thing. I'm just wondering if there's anybody listening that has had success in working with your hospital in either like reducing the medication before or discontinuing the medication before they're admitted, because we have heard that some discharge planners work on that. Is anybody doing any of that kind of work that you want to share? And just a reminder, if you'd like to speak, just click to get in queue, just it's star and 1 on your telephone.
I think there was another comment to this month.
Oh, yeah. Okay, yeah.
What they include everyone.
They have a medication management meeting monthly with DNS, the social worker for the pharmacist, which includes looking at the behavior notes from the behavior meeting that involves the floor staff.
Yeah, so really get everybody's input, which is nice.
Very, very important.
Kate also has a note up there too that they do
monthly.
Yep, and review all the medication. Yeah. I'm sure make that decision about is the person at a point where we can even try a further reduction or discontinuation of the medication.
Right.
It really takes a lot of communication, I think, is what we've learned, and really from all shifts, making sure that you get that input of what is the person like 24 hours a day? Are we really addressing their needs? And what other things have we tried?
Yeah. And it seems like, we're talking about being fairly siloed. So we're having a meeting on antipsychotic meds, but as we're talking, this really just is about the use of inappropriate medications altogether. And to be having like these timeouts that we have for antibiotics, we should be talking about antipsychotics, antibiotics, opioids, all of it kind of falls, and it's like we can kind of probably move beyond just the antipsychotic medications and really change our system. So we're looking at the reduction of any unnecessary medication, or getting them down to really small, small effective doses. We've been spending so much effort just talking about antipsychotics, but there's a lot more.
Yeah.
Or other, anti-anxiety, benzodiazepines.
We don't really want to continue. Sometimes we do have a reason to utilize them, but they shouldn't be considered like a blood pressure medicine that you're planning on leaving on. They should be considered short-term medications only.
Absolutely. And I love the idea where, with the research that was done with the 45 days of the opioid, and how does that get into general practice, and how do you, just takes time.
Yeah, I don't know what the time of that is for antipsychotics. It probably is. I think a lot of times it just gets started and they're just on.
Yeah.
Which is unfortunate.
Yeah. Well, since I think maybe some of you would like to talk about some barriers that you're having. Why don't we move on? Oh, and then let me first just share something that Dana has written. We have monthly meetings with our pharmacy consultant, clinical manager, DON, and nurse practitioner to review antipsychotic med use and if a GDR is safe to attempt. And we've been successful in reducing the dose they're on. That's great. But again, Jennifer is saying that, excuse me, I'm sorry. This is a difficult conversation to have as doctors, hospitalists don't like to have limits or requirements put on them, and once families see medications that work, they're very upset when GDR doesn't work. Yeah. So that goes well, and this kind of brings us into some barriers, too, that we're going to be talking about in a minute. It's true.
A lot of it, like we talked about, is communication, and often you don't get to talk to the hospitalist before somebody's transferred or really get a good picture of that person. So I think, it's having those conversations with discharge planners of hospitals and talking about that as best you can ahead of time. And then, we can talk about a little bit younger barriers about when gradual dose reductions don't work. But I think we're really wanting to assure that we're looking at appropriate use of the medications for people with dementia. And what the research is all saying is that most of this is unnecessary. Isn't that right, Jane?
Yep. That is what the research says. When you really look at the data, there is no, I think the benefits that we're seeing may be a bit of our own biases. We're seeing benefits where there really aren't any. And that's a hard thing for us as providers to convince ourselves of. But when you look overall, there really isn't evidence that these things are helping us, even when sometimes we think they are. And I think with families too, I think it's being straightforward that this is dementia is an illness that is associated with behaviors that are different than what the behaviors your mother, father, whoever had at a different stage in life. It doesn't, and unfortunately they aren't things that we can medicate away because they are part of it is sometimes part of the disease process, and it's more around how we react to it than that we can treat it. We can maybe mask it, which I'm not sure people necessarily always, once they look at it that way, they're still having this. We're just masking it right now.
And what we're hearing a lot from homes that are having, really trouble getting, that really have high rates, is that they feel like their gradual dose reductions aren't successful. That as much as we say, well, it doesn't really help, in the mind of the staff, it does help because they're not seeing these behavioral expressions anymore.
Right.
So,
but they're being masked.
They're being masked. So sometimes what's happening is they're being taken off these medications sometimes rather quickly.
Yes.
And so when it's not really slow, and again, the consultant pharmacist who gave the nice talk that we had really made the important point that you have to do this, especially if they've been on high doses for a long time. You have to take it slow. And if you just start taking these medications away, of course you're going to see some stuff. And you're going to just chalk it up to, well, they need the medication and put it right back. And you really have to do it thoughtfully and slowly and carefully, and know that, and expect that you're going to see something emerge, because that's why they were put on the medication, but be prepared to kind of figure out what it is that, why are they what is the reason that they're having this expression, this behavioral expression, and let's see if we can't figure that out and try to meet their needs instead of just masking it with the medication.
I think the balance of that is, like we've already talked about, the music and memory program. You know, homes that are really, as they decrease the medication, they have options for residents. You know, it may be that, you know, is the resident bored? Do they need to move? Are they in pain? Are they, as you're taking away these medications, they're certainly going to feel more things. So, you know, deciding what that is, and I'm not saying that you put a set of headphones on them and shove them in the corner and gee, they're happy, but you know, it's really being connected with them and learning about them and really observing the behaviors. And I think I think you have to start a tracking program, and we've seen homes that have done this, of saying, instead of saying what are those behavioral responses that are negative or challenging for staff to deal with, as we do the dose reductions, what are we seeing as positive in this too? You know, is the person more alert at certain times of the day? Do they become more restless at certain times of the day? And how can we really change our care plans and our interventions and our interactions with those folks so that we're changing as they're coming off these medications? We're really changing how we're approaching and working with them.
So Dana has something here that she's shared in chat. One of the barriers we have at times is the family not wanting to try a GDR because they see their family member as stable, and they don't want to cause them any undue stress by attempting a reduction. Does anyone have suggestions or tips on how they worked with the family? I think before we jump in, I would hope, is there anybody either on the phone or in chat want to share some successes that they've had working with families? This is okay, so maybe not, but this is another thing that, you know, we hear a lot. So this is a common barrier that we hear. And it's understandable, particularly if a family member maybe had their mother or their father or their loved one at home, and they were hard to manage, and they found that using these medications helped them be more manageable, and they were able to see that in their eyes they were better. And then you come to the nursing home and you want to take the medication away. So, yeah, this can be disturbing. But I guess you have to think about is, have you had that conversation about the risks? Are they aware of the risks of the medication and really all of the ill effects of these medications, and make sure they understand that, and have them be part of the team that helps figure out, again, since they know their loved ones so well, they can actually be part of the solution of what is it that, you know, before, you know, when they were able to express themselves, what is it that calmed them, or what did they go to for comfort, so help us understand so we could try those things too. And you know what, if we will gradually just try to reduce the use of these medications, and if it doesn't, and with your help and using these other strategies, and if it doesn't work, it doesn't mean that we're going to just keep taking it away. That there's always an option of keeping the medication on, and just make them part of that team.
Yeah, I think some of the conversations with homes that have been successful in broaching this has been in having those discussions up front, maybe an admission with persons who are admitted with the diagnosis of dementia, is talking about how your goals are to get rid of unnecessary medications. Also giving them education about how dementia is a progressive process. And even though they've been living with their loved one for many years, as this disease has progressed, their needs now of being in a skilled nursing facility. Obviously, something has changed to reach this point, and you as the providers or the team now working with this person really are the ideal people to begin to enhance the quality of life for the persons with dementia, and to be able to get rid of medications that they no longer need, and to look for other ways because of the services that you have in place to improve their quality of life. And so getting that family to be part of that partnership, I think, is really important, and to build some of that trust, and to have them be part of the team whenever possible is where we've seen the most success.
And Melissa shares here that they educate the family members and assure them if the GDR doesn't work, we can resume the dose they were on prior. Most families are okay after getting the information on the effects this medication can have on them, and they are also informed that we will continue to monitor whether it's successful or not. And they might even be pleasantly surprised that as the doses are reduced, that their loved one is actually more alert, more participating in activities. It might be like a nice little surprise that they didn't realize that